Welcome to Healthcare Rounds. I'm John Marchica, your host today, and I'm really excited. I'm going to be speaking with Bill Lane, Executive Vice President of Network Development at Illumed. So Bill has spent over 15 years with Humana and has had many leadership roles regarding hospital system contracting, alternative payment models. And actually was part of Humana's adoption of CMS's first or primary care first model. So we're going to get into more of his background here, but today the focus is on value-based care, accountable care organizations, and why we need to pay attention to these things, and what the state of the union is today. So, Bill, thank you so much for taking time to talk. I really appreciate it.
My pleasure.
So we were talking for just a minute before we started recording, and I said, I really feel like, where we are today, it's almost like population health, this term that everybody throws around, population health, pop health. Are you in pop health? Yeah, I'm in pop health. But it means different things to different people, and it's almost like it's taken on this era of almost like it doesn't mean anything. So that's kind of how I feel about value-based care. Like, a lot of people have a sense of what it's about, but maybe definitionally they're not quite there on really what we're talking about. And so maybe a good place to start from your perspective, if we were to roll back the clock to like the late 80s, 90s, and managed care revolution, right? Talk to me about where we were at that point in time, and then when we started to see this sort of idea of value-based care take shape.
Well, it's a great
big
intro.
question. I know.
That's a big question. Well, understand, I'm not that old, but old enough to remember back in the day when your parents were guiding you through your life, and you want to get a good job with insurance, right?
Right.
Make sure that insurance, and I'm talking as far back to the early 80s, when I was graduating high school and going into college, and back when you had employer-sponsored healthcare, it was an indemnity plan, and health plans were known. The Cadillacs, right? Blue Cross Blue Shield, indemnity. Go to any doctor you want, and the physician, the provider, is indemnified for that covered service. And then you have usual and customary, and all these terminologies. It's whether people are aware or have an understanding of what those terms were. There was little attention paid to, oh my God, HMOs. That was a dirty word, dirty acronym, right?
Yeah. So, well, just to interrupt briefly, the insurance that you're talking about, the indemnity insurance, if we have anybody like under 40, I'm not that old either, Bill. You and I are about the same age, so let's just say we're both young. But anybody under 30, 35, they might not even know what that is. That's right. Like, the way I describe it is it's almost like your car insurance. Now, of course, you pay a premium. Your car insurance isn't paid for by your employer. The indemnity insurance very often was, right? Or at least most of it was paid for. And then all of the machinations and the agreements and everything was kind of happening in the background. And maybe you would get a bill, right? This is what was not covered. And now you've got to write a check for your whatever part of the doctor's, whatever the difference was. But it operated very much so like car insurance. And then into the dirty word, as you said, HMO. Yeah. What was different about that?
Yeah. So population health, value-based care, alternative payment models weren't even a gleam in people's eyes back to any great extent, right? In the 80s. And it was largely driven not by Medicare, but by private health insurance, starting with the HMO Act in 74, Kaiser Permanente latched on to that, and their staff model. I'm going to probably add fuel to the fire of confusion of acronyms, right?
That's fine.
But then you had an initiative where how can we best control care, managed care? How do you manage the care? hopefully not to the detriment of the wellness of those patients being treated, but for the cost of care. It was really largely a cost model. We're going back to the 70s, early 80s, the introduction as a diversion from health maintenance organizations where you had the pre-authorizations, the referrals, and so forth. PPOs, preferred provider networks, basically HMO light. You didn't need a referral. They were broader networks, and they did cost more money in terms of premium, but that seemed to be the solution. And I'm talking from the lens of from the health carriers. So PPOs have those preferred provider networks proliferated largely, and that became kind of the currency of value-based care. Not really value-based care, but in terms of managed care. So it wasn't really until the 90s that it became a little more better understood of, oh, I have a PPO. I can only see these doctors on this printed directory. Otherwise, I'm out of network and I'll have to pay the freight like an indemnity plan. And that didn't go so over because they have out of network claims and so forth. Urgent and emergent care was cared for as a network and so forth. But the advent of what we now know as value-based care, really its origins hark back to those times where you had either a gated network, in other words, the referral required, or a PPO, still the conundrum of making care effective and cost effective, most importantly. That became the onus of a lot of private insurance companies. So think of Blue Cross Blue Shield, Aetna, Humana, where I came from, and so forth, and some of the smaller players. Again, from our perspective, what we're hopefully going to talk about is alternative payment models or value-based care in the Medicare space. It wasn't until the passage of the Affordable Care Act back in the early aughts where you had CMS by that legislation creating the Centers of Medicare and Medicaid Innovation. Okay, and that was the advent of accountable care organizations going back to 2012. The Pioneer model was the first dip of the toe into the value-based care arena or alternative payment models, which CMS launched, the Pioneer model. And then from there, expanded that reach to what we now know as MSSP, Medicare Shared Savings Program, the hundreds of ACOs out there that are participating in that program. And there have been iterations above and beyond that. Okay, not answering the question, right?
That's right. That's right. So before you answer the question, I just want to put some context. I've talked about this before, probably in healthcare rounds, but just to put it in context of my role in all of this. Mm-hmm. So when I started in graduate school the first time around, I was at Chicago, and I got lucky actually through a contact. I got an internship. My internship was for the American Association of Preferred Provider Organizations.
Oh, sure.
And they were doing an employer survey. And so my internship was to conduct a survey. It's probably a couple hundred people. Somewhere in my mementos box, I still have a copy of the results of this because it was one of my first projects that I worked on. So I had that familiarity pretty early on. I started working on that project back in, 1988. And then I was the managed care analyst at Abbott. So I had exposure at that time to the dirty words, the HMOs, mm-hmm. right? The dirty acronyms. Although I don't think that we really approached it that way, but it was kind of like in the early 90s, it was this new customer class, that you really had to work with. But the thing that I would say is at that time, the managed care, at least the perception was that it was you could get to where you wanted to go by denying mm-hmm. claims or cutting costs. And there really wasn't, at least, again, this is retrospectively looking back, a lot of talk about the triple aim, which didn't come about until 01 or something like that.
Yeah.
And then the final piece of the puzzle, and then I'll turn it back to you. When I went back to school the second time around at Dartmouth, in our doctoral seminars, we were talking about these value-based care models. I mean, that was among other things, but that was part of it. And Elliot Fisher um, from Dartmouth was one of the people who, and actually you can see him on Healthcare Rounds, and I think an episode we did a few years ago. But Elliot Fisher being kind of that ACO, I don't know, father of the ACOs. Sometimes he
Mm-hmm.
gets credit in that area. But we were looking at these models back in '06, '07, kind of like as just different ways to pay for different models for paying for healthcare and delivering healthcare. So fast forward now back to you, Bill, and the Affordable Care Act and all these different models, and then back to the original question, which was around, how value-based care evolved from this concept of managed care and why they're different.
Yeah, it's almost stupefying in terms of the amount of information out there. It's overwhelming to most people, even myself included at times, as to where do I start. And when I hear population health, value-based contracting, value-based care, accountable care, they're used to a degree interchangeably because there's a lot of common threads, starting with population health. So let's talk pop health. And what do we mean by population health? And improving the health, well-being, quality of care, reducing social inequities in healthcare delivery for an entire population. So that's from my eyes, right or wrong, the overarching concept of population health. Sure, we want people to be healthy. We want people to um, live longer in high quality of life, not just prolonging life for the sake of prolonging life, but improving the population, regardless of race, creed, rural, urban, suburban, etc. That's our main focus. And from my perspective, as being part of an accountable care organization, and we'll talk, great segue. What's
Yeah,
accountable
great.
care? Okay. Well, it's really drilling down. It's more a vehicle to achieve population health. So, an accountable care organization, we can talk about what does accountable care mean. And I believe most physicians bristle, rightly so. Accountable care. I'm accountable. I'm a physician. I'm the primary care physician for this patient or this patient panel, whether it's 500 or 5,000. I'm accountable. How
Right.
dare you say I'm going to be in an accountable care organization? My goodness. And I get that. I'm not a clinician. I took biology and I think I skated by with a C plus, and that's the extent of my life sciences training. But I've been in this business for 30 years. I grew up. My mother was actually an office manager for a pulmonologist. I can recall doing my homework in the chart room before PHI requirements, and I sat there in the charts doing my math workbook in fifth grade. But the point is, I'm very much attuned to physicians' perspective. We're not suggesting anything that is not accurate. That physicians, of course, are accountable. They're doing a great job. How can we improve the delivery of care without impairing not getting in their way, but empowering them with the tools to do even a greater job at the top of their license? Accountable care is a vehicle to accomplish that. So what do we mean by accountable care? Really, there's two facets to it. There's the cost equation and there's the outcomes equation. And hopefully they intersect, right? So if you're doing a good job in terms of care management, seeing your patient, keeping them out of the hospital for unnecessary admissions, keeping them post-discharge, going back to the hospital for another 30-day readmission, keeping control of their polychronic condition. And most seniors have more than one condition, whether it's diabetes, COPD, chronic kidney disease, among other things. How can we help that? And I'm talking primary care. The specialists are a whole nother conversation. But what I'm talking about is where the rubber hits the road with those primary care physicians, and how can we help empower them to be not more accountable, but more effective in the cost and quality of delivery of healthcare. And that's really what accountable care organizations hope to accomplish. And there are many out there that are doing a phenomenal job improving the care delivery, helping the physician, empowering them, especially with the headwinds of overhead, staffing, EMR systems, people knocking your door, selling all the different things that they do. There's a lot of distractions out there. So an accountable care organization helps facilitate that and can help you with that glide path, that journey with your patients, and not just, again, improving the bottom line, but also improving the care and delivery to those aligned patients that you have.
I wanted to make a couple of comments. The first is when you mentioned the doctors and their initial reaction, we definitely saw a lot of that initially. And if you went to, kind of like 2016, 2017, some of the ACO conferences that were out there, I think by that time, most of the doctors, at least the ones that go to those conferences, had completely drank the Kool-Aid.
Yes.
Right? I mean, they were all in on the model. One of the things, though, that I think criticisms, I don't know, maybe that's too heavy of a word, of the ACO model is that people say, especially doctors will say this, hey, my patients are accountable too. And when you think about, the diabetic patient that refuses to stay on her diet, or the smoker that refuses to stop smoking, or any other whole host of things that doctors deal with, the primary care doctors deal with, that they say, how do we get the patient to be more accountable? Because, hey, if I'm accountable for my, hemoglobin A1C scores through the ACO, well, my patients, I don't have control over them, but they need to learn to be accountable too. But I don't want, and maybe, so there's that component, right? I'm sure you've heard that a lot on patient accountability.
Absolutely.
Right. And then the other thing is, I don't want to gloss over this. You said costs and outcomes, and I want you to talk a little bit more about that. But for me, when you think about the triple aim, and I've been working on kind of this grumpy piece about why it's not a good idea to say things like quadruple aim and quintuple aim and all of these other sextuple aim. I'm sure we'll have that by 2025. Sure. But the general concept of you can actually provide better care for either the same cost or for lower costs is foreign to a lot of people, because I think that we equate price with value. Or, I mean, just think of it, like, you're going to buy a Ferrari or you're going to buy a Honda. Are you going to buy an Armani suit or, off the rack at, Men's Warehouse? And we use price as a signal, and we think about those things. We've applied it to healthcare in some way. And the ACO model says, well, wait a minute. And this comes back to the, Don Berwick and the IHI and all of that. Hey, we can, if we do this right, we can actually take better care of populations and save money, and all the while have people have a better experience with healthcare. And I don't think that we can underscore that enough, that that's, for a lot of people, if we were to go back in time, the managed care days, people would say, well, wait a minute. No, you pay more, you get better care. Or if you want to reduce costs, you just don't approve things, right? That old managed care mindset. But that's not what accountable care or value-based care models are saying. Right. It's saying, how do we improve care while not ringing the cash register, or, constantly increasing? How do we make it better? How do we improve outcomes? And so, the nuts and bolts of the way that I describe the ACO model, and please tell me if I'm wrong on this, is if we just look at the Medicare example, but a lot of the commercial ones try to be similar to this. And the Medicare example says, look, we think it's 2024. We're going to look forward to 2025, and we think you're going to spend this much money, right? Or you're going to get reimbursed by this much money. We're going to project that. And then 2025 happens. And then at some point in 2026, we look back and we say, well, we had a projection, we had a budget of what we think that you would have spent on this population of people, given how sick these people have been given all risk adjusted and all of that.
Yes.
And if you came in under budget, great. We're gonna have what's called shared savings.
Right.
And at least in a full risk model or two-sided risk model, if you come in over budget, if you spent more or were reimbursed more technically, if you spent more than we said you were going to spend, then you got to write a check to the government. And we're going to split those losses, right? So if we said you were going to spend 110 million and you spent 120, that $10 million is going to have to be paid for somehow, and half of it's going to come out of your pocket. Did I say that? Is that about right, Bill?
Yeah. Well, there's a common theme when people talk about accountable care organizations. It's all about the benchmark.
Yeah.
And that's what you just said. And as well, for us, and to give some context, I represent an ACO REACH model. So you have MSSPs, A, B, C, D, E, enhanced. Next generation is gone. Was superseded to a large extent by direct contracting, the DCE model program, which has now been overtaken by ACO REACH. So I sit squarely within an ACO REACH global risk model, 100% Part A and Part B, not D. So for all those original Medicare beneficiaries that we're responsible for in 14 states, 74,000 and change, traditional Medicare beneficiaries, we're responsible for the total cost of care. For Medicare reimbursement, we perform the function as a payer. So the ACO REACH is significantly different than MSSP, where CMS continues to pay the claims. So the ACO REACH model, we're the delegated payer for physicians, for primary care physicians in particular. Okay, so with that, we can get creative. And so how to build that platform to incentivize that best practice behavior. That's one side. You teased out another, patient behavior. So how can we make that marriage as happy as possible? The PCPs and the patients, those aligned beneficiaries. And there's a couple ways that the traditional Medicare beneficiaries are aligned to a PCP that we contract with and we're the claim payer for. It's either claims-based, CMS tells us the aligned beneficiaries to that PCP we have in a contract, or in the instance where they're seeing that PCP, they have the ability to voluntarily align. And why would they do that? Because ACO REACHes, such as my organization, we offer beneficiary enhancements. So there's a couple things that we approach, cost share support. So instead of you paying the 20% to see that PCP for your, whether it's annual visit, hopefully it's more, I'll get to that in a moment. We take that. In other words, we pay the PCP for that cost share, removing the barrier to that care. So a lot of instances, a patient will say, we have patient outreach, non-clinical, that reaches out to those aligned beneficiaries and saying, hey, it's been 2 months since you've seen your primary care. It's like, well, it's either I eat or I see the doctor. Some people are in that scenario, for their socioeconomic situation, they can't afford that cost share, that 20% of that Part B cost. So they go, well, wait, it's no cost to you to see your PCP. What's that? You need transportation. Yet another beneficiary enhancement the ACO REACH affords us to deploy. We can provide transportation to the PCP. Again, no cost. And some other bells and whistles that we have, chronic care reward program. If they adhere to a treatment plan, there's a gift card that we can put out there. So on the patient side, that we meet them where they are as well. And in terms of the PCP, we provide them with upfront per beneficiary per month upfront cash. No cost, no recovery, no clawback. That's an investment that the ACO Illumed does for those PCPs. So the expectation is that they will see the patient at least 4 times, once a quarter, 4 times a year. And with that, a lot of magic happens. You can get ahead of those conditions that are either being not treated or maybe not even diagnosed. So a lot of people have, when I say dormant, unidentified conditions that can be addressed if they're seeing the physician on a regular basis. And with
Bill,
that, yeah, go ahead.
just quick question. What is your compliance like on that? If your goal is once a quarter, what's the reality of what you're seeing with patients in this model? How often that they actually make it in?
It's probably in the mid to high 50s. So 50% of our PCPs and our contractors seeing our patients 4 times a year.
That's incredible. That's I mean, because the way I'm thinking of it, if you can get somebody in at least once a year, but if you can beat that and have them coming in 2, 3, 4 times a year,
Yes.
to your point, you're flagging things because before they become a problem, hopefully,
Yeah.
or if they have chronic conditions, they're being better managed because they're being seen more frequently.
Yep.
And I would think there's a kind of a knockoff effect of patients sort of feeling more accountable in the sense that just they're engaging more often with their doctors. And so maybe
Absolutely.
they feel like they're more of a part of their healthcare,
Yeah.
right? Does that sound
No,
about right?
100%. Yeah, I'll even go one step further in terms of outcomes, or where does the cost equation intersect with quality and outcome, and whether or not this is an outcome per se, it is not. But when I look at the financial performance, because again, it's a cost model, but also cost and quality. So when I look at our top performing physicians, and one of our guideposts is seeing the patient within 3 days post discharge. But wait, CMS tells us 14 days. Isn't that good enough? Quick answer: no,
No.
it's not. It's not. So, okay, is this some abstract number pulled out of the air? Understand the leadership here, myself included, came from immersed in managing global risk for Medicare Advantage. You had all the levers, you had the gated network, you had subcaps, you had either you covered or not covered. Okay. So what we have here is traditional Medicare beneficiaries, no gated network, no network, even though we say it's a network, you can go anywhere you want. So how do we best control the uncontrollable? Well, one of the things that we do, as I talked about, is seeing the patient at least once a quarter. And most importantly, if they do find themselves in the hospital, and I say do find themselves, that's so glib. Unfortunately, people do have to go to the hospital.
Of course.
When they get discharged, the expectations of the PCP with that upfront cash that we pay them, the expectation they're going to do that follow-up within 72 hours post-discharge. What's the results? Let me check here. About 40%.
It's really good.
No, it's not. But what I will share with you is that the top
Your standards are
performers,
higher than mine, Bill.
the top performers who are seeing the patients 60% or more within 3 days of discharge are killing it on the cost side. Their benchmark is here. Oh, wait, here. Okay. And their spend is here on a per beneficiary per month basis. So what that means is that they're not only delivering awesome care and seeing the patients as much as possible, but they're beating the pants off their benchmark.
That is amazing. One thing I don't want people to lose this part. So in the traditional MSSP model, and by the way, Bill listed off a whole bunch of models. If there's any demand for somebody to explain all of these and to do a supplement on healthcare rounds, I'm happy to do that. It might put some people to sleep, which is
Yeah.
why, Bill, I don't want you to go through these now. But um, in the ACO Reach model, you're given a global payment or a per member estimate,
Mm-hmm.
right? And then you're the payer. So
Yes.
you're actually with every claim. And so you're really close to knowing who's above benchmark and who's below because it's like it's all happening in real time
Yes,
through
to
the
a larger
ACO.
extent. Yeah. What we do, to give you a little insight there, well in advance of us signing someone up, yes, indeed, we are making informed decisions. We partner with one of the well-known CMS data aggregators, CareJourney. Shameless plug for them.
Mm-hmm.
So we have ready access to historical original Medicare claims data. So within that, it gets very, very granular in terms of, the NPI, the practitioner, how many aligned beneficiaries they have, what they're, where they're spending their money. Where are they spending Medicare's money, I should say?
Sure.
How often they see the patient, what's their average risk score of their aligned beneficiaries, hierarchical condition category, HCCs. So we have line of sight to that. So we can pretty much project as to if they were participating in a model today, how they do. And there's some folks out there, they're focused, right or wrong. That's like I see them once for their annual wellness visit. Good to go. See you later. That's probably not the practice that we want to engage with, unless they're just champing at the bit to be schooled up. But there's not enough time because, as you said, we get a benchmark from CMS based on the historical claims utilization of that physician. So to ramp them up, we're not in the training wheels stage in our model. Those are some that I ticked off: the A, B, C, D. E, enhanced, and starting after A and B, you get into the risk share part with with CMS, but it's not 100%. The top rung with enhanced is 75% upside only. But anyway, we could go down that rabbit hole very, very quickly. But in our world, with this particular model, this is high risk, high reward. And for that, we have to be very mindful as to what partners we select. So far, so good. We had a very good year in 22, likely to be similar for this past year. Of course, with the CMS models, whether it's MSSP, ACO REACH, or anything else for that matter, it's always the reconciliation period occurs months after the close of the performance year. Right. So we will see how CMS MSSP models did sometime this coming fall for 2023 last 23.
Right.
Yeah.
Right. And, in my opinion, one of the problems with the ACO model is the delay, in when you actually get punished or rewarded for your behavior.
Yes.
And to some degree, the actual degree to which you get penalized or rewarded for your behavior. If you've spent as a physician practice, let's say you're a physician-led ACO, I'm thinking of like Commonwealth here in town. That's kind of like that, about 100 doctors. If you invest all this time and effort and you get a check back or your investment or something for, $800 at the end of the year, it's kind of like, well, why did I invest all this time and effort? But Mike, I had two questions for you. One is, in 2024, do you find that doctors are self-selecting to be part of things like ACO REACH and part of your organization? Or are you still getting a whole bunch of, oh, I guess it's an ACO, I guess I should be part of it? Do you find that the ACO model has been around long enough that you're getting some self-selection of better performers, or at least people who have bought into the model?
Well, I'll check my phone. No one's calling me. No, in all seriousness, there's a significant market consolidation. Okay, so there's been about 1,200. Let's start from the top. There's approximately 1,200 ACOs since its inception in 2012. There's currently around 500. There are more ACOs that dropped out of ACOs than there are today, still participating. Okay, so MSSP, the battle lines have been drawn. Those that are in those ACOs probably going to stay there because they've been in there multiple years, assuming, of course, that their organization is transparent and giving them the reporting data and providing them the support. Sure. And if they earned $20 million, I'm sorry, if they earned a surplus of $20 million, that will be distributed fairly and equitably according to the contract. And for those that don't, we do find some attrition and those people seeking options. I think that's what you're talking about. My phone is still not ringing, by the way, but those are the folks that are considering options. Hey, I'm in this accountable care organization. I've heard of you, or I've seen your flyer. I saw you at a conference. I'd like to learn more, and that's kind of where that is coming from. A lot of referrals. A lot of folks that are dissatisfied where they are today. But to your point, yes, there's what we call the selection effect. Those that are successful are eager to earn more, and the ACO REACH affords them that vehicle to do that versus the just upside only, risk reward, right? This is economics 101. The more you put at stake, the better the payout could be. It's like, I don't want to say the analogy is Vegas, but if you put the odds, right,
right,
it kind of plays out that way. But again, it's not a land grab as it was. Not that we were involved with a land grab, but there are a lot of folks out there that are still engaged with the trying to build market share. And
sure.
We are too, but good market share. Hopefully those folks that do, my phone's still not ringing, John. But anyway, the point of the story is, there's a lot of out there, and there's a selection effect indeed. Why are they calling me? Yeah,
they're still not calling it. But the follow up question is, and I don't know if you track this, but it's always been my sense that there's a pretty substantial spillover effect in terms of, let's use your example. If of your ACO patients, your Medicare patients that are in the ACO, that it's sort of a goal to see them once a quarter. And then you start seeing the benefits of seeing patients more regularly. Wouldn't you take that same approach with your entire panel of patients? Like, hey, maybe it's a good idea that I go talk to, or that John comes in for his, because he's not of Medicare age, that
right.
John comes in at least a couple of times a year. And the same thing for your diabetic populations, those that aren't part of the population. Like, it seems to me that habits developed or habits encouraged in the ACO model spill over into patient care generally. What is your experience? That's me as a sort of a researcher, but what's been your experience there?
You teased out something that I was meaning to talk about in terms of influencing physician behavior. And a question came to me about 18 months ago. I wish it came to me much earlier. And that is, okay, doctor or doctors, you're a primary care physician organization like Sleepy Hills Primary Care in a fictitious state. Okay, there's 1,000 beneficiaries that, yay, we win. Oh wow, what a great pickup that Illuma just got. Another 1,000 beneficiaries. What percentage of this 1,000 represents of your total patient panel? Is it 10%? Is it 20%? If it's underneath 20%, the likelihood of us, whether it's me, my chief medical officer, our clinical team, our CEO, our CFO, our COO, influencing their behavior is going to diminish greatly if it gets under 20%.
That makes sense.
Okay.
That makes sense.
And I came to that realization, like, why aren't they? This is great. They're doing so well. They could be so much better. They should cross-pollinate this best practice to their entire, and that would make it so much easier, separate apart from EMR systems and remote patient monitoring and data analytics and pop health platforms and all these things that are distractions, quite frankly. It's shovels and picks. We're talking shovels and picks here. If you go to one of these managed care conferences, your head's going to spin. I love all those vendors. They have great products, but they're peripheral. They're peripheral. Right. Okay. They're nice compliments to have, and we use many of them. But at the end of the day, it's practicing. Again, I don't mean to say they're not practicing good medicine, but seeing the patient. It's like, see the patient. Yeah. See the patients, and if they find themselves in a hospital, make sure you have an open slot for them to come in. or, it's not just a face-to-face. We do provide support for telemedicine as well, but you need to have that patient engaged. They came home with a big bag of medicine, 10, 10 prescriptions. How is an 80-year-old widow going to manage through that bag of scripts?
Not very easily.
Not very easily. The likelihood of her bouncing back to the hospital because of either an adverse drug reaction or not taking it twice a daily, whatever the case. I'm not a pharmacist, but I've seen this in action. And for those doctors, our top physician, I mean top, actually, he's a phenomenal practitioner. He spun off from an existing group, and he came to me and said, I like to go out on my own. I go, you have our support. Do you know how many aligned beneficiaries he had on day one he came on with us? 0. We deployed voluntary alignment forces. We got him up to 600 within 1 month.
Wow. That's really good.
You know what is hit? He's seeing the patients 83.3% of the time within 3 days discharge.
So he's clearly sees not only the benefit but the results.
Yeah.
And if he's one of your top performing people.
Absolutely. It's nothing magical here.
And that's what it seems to me like so much of this is common sense. But, I forget the saying, but it's like that which you don't measure, you can't improve, or something along those lines. And so just simply the fact that you're paying attention to some of these things that seem like no-brainers, but for other people, like you said, if they've got a small Medicare population, they're probably not right for you, but maybe they just have a different view, and they're not going to be even if they became part of your group, they're not going to be influenced by some of the things that you're looking to accomplish.
Yeah, no, it can get overwhelming.
It can be, and some of the early complaints were all the reporting, right?
Yeah.
Like we got to put all these systems in place. We got to report this to here. Here you're pulling from this database. Here we got to report directly, and so it kind of got confusing for a lot of at least early on. So if we had another hour or two, Bill, would really get into it even deeper. But where I want to go from here, because we only have a few more minutes. I want to be respectful of your time and of the audiences as well. So where we are, just looking to the future, that there's this, I would submit that at least in concept, the idea of value-based care has been around long enough that pretty much so, I think most people are on board, most doctors, whether they're actually engaged in doing that, but they understand the concept, and they understand we're moving to this, hopefully, this goal of improved outcomes without raising costs. Where do you see things headed in terms of value-based agreements? And maybe just starting, because as I said, we only have a few minutes left, but starting like what you think Medicare might do, and then on the commercial side, what you see for value-based care models in the next 2 to 3 years.
Oh boy. Deep breath. Well, I hesitate to speak on behalf of CMS.
This is Bill Lane's perspective. This is
my perspective, and I think I can,
or Element's perspective. It's just your perspective.
No, absolutely, and I say that a little tongue in cheek because we do have a very strong and productive relationship with the leadership team, the deputy director of the CMMI, Liz Fowler. We have an open channel of communication. Actually, a few weeks ago, it was a National Association of ACOs conference in the spring in Baltimore. And the direction is thus. It's not going to stop. I'll make that very clear. The die is cast. ACOs are going to be with us. To give you a distinction, we're a model. ACO Reach is a model, demonstration model. Medicare Shared Savings Program is a program. That is now bolted on to CMS. Okay. That's not going anywhere fast. So the question comes, okay, where's ACO going to go? Likely either dovetail as a program. Unlikely they're going to create a new model. They may extend ACO Reach because it was a 5-year demonstration, direct contracting, change to ACO Reach. Hey, we're a new model. Give us a couple extra years. So that has uh, that has promise as well. But at the end of the day, whether it's ACO Reach, MSSP, they introduced a few weeks ago, actually, a month or so ago, the ACO PCP Flex model,
Mm-hmm.
which is a tack on to low revenue MSSP. We're going to really confuse people when I talk about low revenue MSSPs, but that's okay. It's a smaller subset or small subset of MSSPs whereby CMS will offer an additional program that blends it or incorporates with the MSSP strictly for PCPs, for the ACO rather, but the investment model is a $250,000 upfront investment. It's a low interest. No, it's a grant, not a low interest loan. It's a grant. We can go on about that. But at the end of the day, these are all advancements to the ultimate goal of CMS, which has been stated thousands of times, that CMS wants to have every single Medicare beneficiary aligned to a value-based arrangement. Here we go again, another value-based arrangement, whether that's primary care first, an ACO model, which up to and including the PCP Flex model, ACO Reach, which may have another iteration, either as part of MSSP. So all these things, again, are advancing toward the ultimate goal of CMS stated multiple times to have everyone in an accountable care like model. Doesn't have to be an ACO by 2030. So
Does
what happened?
Medicare Advantage fall under that?
Actually, yes, it does.
Yeah.
Yeah. Oh, so let's take a step back. So what does that mean? 60 million Medicare eligible folks out there. Me within a few arms reach of that. I'm not sure what I'm going to do, but the point of the story is half of them, 52% actually, are in Medicare Advantage plans. So what about the other 48%? What are we going to do about them? That's where we're here.
Right. From CMS's perspective, they don't care. I mean, it's just they want 100% of they want all people either being quote unquote managed through a Medicare Advantage plan or through any one of these accountable, whether it's a demonstration project or it's a fully functioning program,
and
just fully covered.
And the backdrop of that is because, this is not talking about economics, but it's been kicked around for some time in terms of the solvency of the Medicare Trust Fund. And that has been projected to be, we're talking the Part A, that's the hospitalization piece of the benefits that will be unable to meet its obligations by 2030. Oh, that sounds familiar, 2030. So that's where that intersects. And whether it's 2020, 30, 2030, and, not, again, we could cover so much ground here because people are living longer. Are they living better and healthier lives? That's up to debate.
Sure.
But in understanding that there are more people like you and me, and less people age-wise, that is, that are going into the payment system. So think of, Social Security, Medicare, these entitlement programs. I say entitlement wincing because entitlement, I paid into it. Don't I get it back?
Yeah.
So,
right. I'm kind of with you on that one.
Yeah.
I'm with you on that one. Well, listen, Bill, we could talk. We have so much more to talk about, but again, timing. Maybe we can do another one in 6 months or whatever the case
I'd
may be.
appreciate
But
that. I'd
just do another one, kind of go through how things are progressing with you.
Yeah.
Lots to talk about with respect to ACOs and value-based care. So I'll look forward to part 2, and I'm promising our listeners that we're not going to wait 2 years to make that happen. That Bill will come on again, and we'll continue to talk about these. But I mean, this has been great. Thanks so much, Bill. I really appreciate starting the conversation here.
Yeah.
It's exciting. It's really exciting. I know a lot of people look at this with, a lot of trepidation and worry. Where are we going? I think it's exciting. I think that enough people are looking at healthcare improvement and doing it right, that these are good times. So
I appreciate it. I welcome the opportunity to speak again with you. You're a great host.
Excellent. Thanks again. So everybody, that'll do it for another episode of Healthcare Rounds. Our guest today has been Bill Lane, Executive Vice President of Network Development at Illimed. As always, I'm your host, John Marchica, CEO of Darwin Research Group. Now listen, you guys hear me say this, and usually it's a recording, but I'm not like a recording that's going again and again. Now I'm actually asking, please, Spotify, Apple Podcasts, wherever you get your now we're up on YouTube, wherever you get your podcasts. If you like what you see and what you hear, please give us a rating. If you don't like it, don't bother. I'm just kidding. If you don't like it, certainly give us that rating, but maybe reach out to me and tell me why, and maybe we can make Healthcare Rounds better. So again, thanks to everybody, and we'll see you next Healthcare Rounds.
Thank you, John.